Introduction, and I'm really sorry for the delay in joining because we are facing some internet issues. I would like to switch off my video so that I really don't get disconnected in the middle, um, and straight away go to share my screen, so that we can start off immediately with the presentation. Today's topic is, as already told, is very, very important, and we face all sort of problems when we deal with patients, not only in palliative care but also in all other scenarios, all other specialities, and we generally have a system of kind of slipping down to a situation where we really find it hard to balance out the good and the bad. So we'll start off with the objectives. Basically, we'll be looking at the definition of ethics. Then we all know about the four cardinal principles, but then we'll revisit each one of them. And I'm basically going to discuss on case scenarios so that we understand the situations that generally are ruled by these cardinal principles, and the gray areas, or the merging of certain principles where one is above the other, and we have to choose between the two. And then, of course, when we talk about palliative care and ethics at the end of life, we generally would like to discuss a little bit of euthanasia also. So, by definition, ethics are a moral code of behavior, and ethical principles are a set of principles which should function as an analytical framework that expresses the general values underlying the common morality. And this particular definition is laid down by Beauchamp and Childress. So, when we talk about ethics in palliative care, these are similar to those of medicine in general, as I already said. Having said this, we as doctors have a dual responsibility. So, one is to preserve life. We have always learned about preserving life because we all become doctors when we are young. We go into medical colleges with the thought, or with the hope, that one day we'll be able to save a life or preserve a life, and the second responsibility is definitely to relieve suffering. Sometime, we might have actually, in a way, might have forgotten about how to relieve suffering. And that is what palliative care is all about. And at the end of life, when relief of suffering is seen, it becomes more important, as in palliative care, preserving life becomes increasingly impossible. And that this particular is actually particularly relevant when we deal with incurable diseases like cancer. So basically, we have four cardinal principles: patient autonomy, which means what does the patient want, and does the family generally is understanding what the patient's preferences are. Second is the beneficence, and definitely, will any of our actions or anything that we do will benefit the patient or not. And then the principle of non-maleficence, where it usually means that any of our actions are will it harm the patient. And then, last but not the least, the principle of justice, which is a fair utilization of the available resources. Now, why are we talking about ethics at all? And what are the situations where ethics or ethical principles be applied in a in a thoughtful manner. So we face certain dilemmas, certain problems, certain situations, and dilemmas are is basically a conflict of moral principles. You are in that moral and ethical framework, but then there is a conflict in these principles, and these occur when a person faces certain situations where adhering to one particular principle might result in the violation of the other. So basically, uh, you know um, just to give you a very simple example, suppose you are riding your car or your bike, and you are actually facing the signal. Okay, now the green slowly turns into yellow, but you are in the middle of that particular signal. So you are actually ethically, you want to cross the signal, but then it's yellow, so it gives you a warning that it's going to be red, but you really don't know when it is going to be red. So you try to cross it over, and at that point of time, you are in a dilemma that if it turns red, you are actually in the middle of the signal, and you might be hit by a car, or you might be taken by the police for violating that. So this is a small example that I thought just came to my mind, and you might be an ethical dilemma is similar moral of conflicts. Yes. So I would like to give you a small example. So you can see this is a patient, and he has a orocutaneous fistula because of squamous cell carcinoma of the jaw, and the patient is an elderly patient with a lot of pain. He comes to the OPD and he's examined, and the surgeon actually finds out that he doesn't have any metastasis. So it's a localized kind of a tumor, but it's locally advanced, and he decides to, go on with the treatment. Now he has to put an NG tube in order to start treatment of the patient. Now the patient refuses, and he refers the patient to you, the palliative care person, the palliative care expert, to for your opinion, or for further advice on this particular patient who is refusing the NG tube insertion. Now, what is our stand here? Uh, if you could give me some responses in the chat, or you can also talk. I can give you at least 7 to 8 seconds if you can respond to that. Anybody?
So this is a clear-cut conflict of uh, conflict between the principle of autonomy and beneficence. You want to benefit the patient by inserting an RT for a disease which is locally advanced, and the patient is likely to survive a longer duration of period. But the patient has the autonomy to refuse any kind of treatment. So clearly there is a conflict. So if it comes to me, this patient comes to me, I will counsel that the autonomy, though he has autonomy, the beneficial effect of this procedure is far outweigh your autonomy. I mean, we'll try to counsel and take consent for nasogastric tube insertion.
Absolutely, absolutely. That is the right conflict that we are facing. Now, how do we approach this patient?
In chat box also, everyone has written, they have told counsel and the patient and explain the pros and cons.
So how do we counsel? How do we approach? What will you say in counseling? So basically,
Dr. Mayuri has answered, ma'am. We should understand the reasons for the refusal.
yeah, for some reason I'm not able to see this chat box, but anyway, it's good that you've read out. And yeah, so it's a ethical dilemma between beneficence and patient autonomy. So let us before even we go and start counseling, let us just understand what is patient autonomy. Okay, so basically, patient autonomy means that the patient is involved in the decision making process. And when we say patient is involved in the decision making process, he has the right to have the dignity, privacy, and confidentiality when he makes the decision or when he hears what is going on with him. He has a right to have the information. And when I say information, it is the right kind of information, not just any information. He has the right to make the decisions based on the his dignity, his privacy, his confidentiality being respected, and having the right kind of information about what is going on with him. And the ultimate thing is that the treatment decision has to come as an informed choice of the patient. And this actually constitutes patient autonomy. Now, for this particular patient, if he is refusing, you said you counsel him. How do you counsel him? He's already refusing. The surgeon has actually sent the patient to you, and he's already in refusal. He just said, I don't know why he has sent me to you. I have already told him, I am clearly telling him that I do not want an NG tube. So you take an informed refusal. And what does informed refusal means? It means, number one, you check the understanding of the patient. What has he understood about the procedure? Does he understand that the NG tube insertion would be a painless procedure? Or does he understand that it is an invasive procedure where he is going to bleed to death? So check his understanding. Does he also think that, okay, this particular tube will be inserted through my nostrils and is going to pierce my brains and I'm just going to die? Is it like that? Okay, so you explore the reasons of refusal. Check understanding, explore the reasons. Explore the reasons why he is refusing, and then step on to counsel him. And when we say counsel, when we talk about counseling in palliative care, it means that we are giving him the right kind of information regarding the process. And counseling would might take, a few minutes to even a few days. So you have to have that patience with you. It's not that you're demanding that patience from the patient. Okay. So you counsel the patient, you give them the right kind of information, that if you think that, if the patient says, well, I think, when you insert this pipe inside my nostril, it's straight away going to hurt me. It's going to get out from my eyes or my ears or, any other thing. So you just correct him. You draw a nostril, you show him the paths where it will be going, where it is going to go, and how it is going to help him. So that is counseling. And then you understand that I have given the patient the right kind of information, but the patient still refuses. He says that no, I understand. It's not going to hurt me. I'm not going to bleed. You are going to take good care of everything. But, sir, I'm sorry. I really won't be able to, give any consent. I don't want this. I will not be able to take it. So your principle has to be to support the patient even when he is not in agreement with your decision. And let me tell you one very important thing, that I have counseled many patients who have refused for NG tubes, and you know, even after their refusals, I have agreed with their refusal, but I've always opened my door for them. I've told them absolutely fine. If you don't want to do it, we're not going to force you. Okay. I do not go on telling him that, okay, it's your decision. Later on, just don't blame me that I haven't told you. I never do that. I just tell him, okay, absolutely fine. You go home. If you find any difficulty, my door is always open. Please come over. I'll check on you. And anytime you think that you can discuss this more about, the tube, I'm always there. I have a lot of time for you. Please come over. Okay. So that is how you take an informed refusal. And uh, in my 13 to 14 years of experience that I've had with counseling such patients have actually come back to me and said, Doctor, I think you were right. I would like to take this, and I'm sure that you're going to take care of me. So that is how you take you respect the autonomy of this patient. Basically, giving him that power to decide on a particular, procedure or particular step, and then uh, helping him negotiate his way out of that particular dilemma, so that your idea of benefiting the patient is also met with, and the autonomy of the patient is respected.
Ma'am, we have a question in
Yes.
chat box.
Yeah.
Dr. Karthika is asking, Madam, if the patient is a child and the refusal comes from parents, what is the relevance of autonomy if the decision is not in favor of child's benefit?
If it is, see, you all actually answered your own question. If it is not in favor of the child's benefit, uh, then we are not going to do it, definitely. But if there is a benefit involved where the parents are actually refusing on behalf of the child, then you have to do the same thing with the parents. Okay, because the child is not actually going to take any decision. But if the child is an adolescent, if I have to say, say around 16 years, he's still a child. But you have to discuss that with him also, with that particular child also. If the child is a pediatric patient, then the whole decision maker is his or her parents, and you have to in a similar fashion, you have to talk and counsel the parents. Okay, is that okay? Is that all right?
Okay, madam. I just wanted to know the whether see if the parents are refusing and that is not in favor of the child's benefit, because if their decision is going to harm the child, uh, does the principle of autonomy hold good there? Because it is not the child's decision; it is the parents' decision. So does the principle of
So
autonomy hold good there? That was the
yeah,
question.
so the here the maker is a surrogate decision maker. Okay,
Okay, ma'am.
it is
Okay,
the
ma'am.
parents who are taking a decision on behalf of the child. So you have to counsel the parents anyway. If you have to tell them about the benefits of the NG tube for the child, you have to counsel the parents. You have to talk to the parents so that they understand that this is a good decision they're taking for the child, and uh, that autonomy will reflect on the autonomy of the child. Okay, it is
Okay, madam.
yeah, it is as simple as that. So if there is a see, there are unconscious patients in our wards. Okay, and uh, there would be, for example, I'll give you a classic example of a glioblastoma multiforme patients. So there are children who would lie unconscious for a long period of time, even 6 months. They are unconscious with an NG tube. So there are certain procedures that we have to do for that particular child, and the autonomy of that particular patient would be from the surrogate decision makers who are the parents of the child. All right. So even in unconscious patients, whether they are children or they're adults or elderly, the surrogate decision makers, the immediate relatives are the surrogate decision makers, and they would be talking on behalf of the patient, and we have to counsel that particular person who is a surrogate decision maker. Okay, am I clear? Okay, so this is another example. So he's a 20-year-old boy with osteosarcoma of the lower end of the femur. He has a large tumor now with multiple lung metastasis and severe anemia, and he wants an amputation. But the procedure is absolutely risky, and you explain the risk to him, but he wants to continue with the amputation. So this particular case is an ethical dilemma between doing good and avoiding harm. Okay, and hence, we think about what are the chances of cure when we talk about this to him, because he wants an amputation, and we have to stop him from going into amputation. Even the surgeon has actually given up, and he says that no, I'm not going to operate on this particular boy because he doesn't have that general condition, and it has already spread to his lungs. It is a stage 4 cancer, and even if we do an amputation, he might actually lose his life on the table. So you have to ask these questions and give him that information. Number one, what are his chances of cure? Okay. Is the survival likely even after doing an amputation, where he, suppose he has a 10% chance of coming out of the operation theater? So will he survive even after that operation being done? And will the amputation, if it is successful, improve his condition? Okay. Is the lung metastasis not going to jeopardize his survival, or his uh, uh, quality of life? So basically, these questions we have to ask ourselves and then explain it to the child. And that's how we are actually giving him the option of not choosing to get operated. Another example is this one. Suppose there is a 20-year-old boy. He has an advanced cancer, and he's under your care. So the relatives have now insisted that issues of diagnosis and prognosis should not be discussed with him. So one day when you go to see him, he's alone in the room, and he gets a chance to talk to you, and he asks what's wrong with him. Okay, so what will you tell him now? Any answers to this question? I'm sure you are facing such kind of situations all the time. So how do you handle this situation?
Dr. Neha has told we say the truth.
Say the truth. Okay. But then, the relatives have told you not to do that. Next day, they're going to actually take, perhaps just tell you that, okay, you've done your bit. Now I'm going to take my son away from you, where, you won't be able to reach him. And you've done a very bad job by telling him the truth.
Ma'am, maybe we can tell him, but keep out the sort of morbid parts about the serious parts about the disease which the relatives might be concerned about.
Okay. How does it solve the problem?
Ma'am, it does not solve the problem, but at least the child would have this thing that the doctor did give him, what he was suffering from. And in a way, you're also respecting the decision of the relatives.
But then he does get a small indication of his condition, and
Ma'am,
that might actually, yeah.
answering your question, I think Dr. Mayuri has answered that, ma'am. First, ask him to tell you what he understands, and then you take the discussion forward from there.
Okay, but then he's absolutely intelligent, and you might, fall into his trap of letting him know.
Ma'am, I think rather than thinking of this as a him or us or a trap or a mind game, we are the ones who are not suffering. He's the one who's suffering. So when the patient or the family first makes that request that don't disclose, that is the time when you have to kind of educate the family about the advantages of having the hazards of not revealing the diagnosis and condition to the family first. Should have, of course, that can't happen at a time when the patient is asking you, but it should have happened at the index when the patient's family asks you to not reveal. And then perhaps first understand what the patient goes. Often, as you rightly said, the patients already know they are coming to an oncology center, they are suffering, they are having pain, they are getting treatments and the side effects of the treatment. So they already know, but we can find an empathetic way of breaking the news to them or explaining to them that it's some we have to find a way. We cannot lie to them because then we all trust in the patient.
Yes, that's a good answer. That's a really good answer, good explanation of that. But what saves us from falling into such kind of a trap where there is a dilemma whether we should tell or we should not tell is bringing both the parties to one platform. Okay, one step after the other. Now, your communication skills would actually come into play when you do this exercise. So first thing that you do is ask the relatives, ask the parents, why did you want to do it? As you rightly pointed out, ask them why, what are their fears, what will happen. So, many times parents would say, my son is going to have a heart attack, number one. My son will not be able to take it, number two. I don't want to see my son, knowing this truth, because after knowing this truth, he will anyway be sad. Okay. So these are three common answers that you might get. There will be different, explanations by the parents or the relatives for that. Now you have to make them understand that your son is already an adult, so he has all the rights to know. So it is about the rights of a patient. Okay. And on your part, now it's your time to understand as a doctor that parents are always protective about their children. We all have children, those who are married and those who have actually had children, so they would understand that we as parents are absolutely protective about our children. We have to understand that side of this parent also. They are trying to protect their child from getting hurt by any manner. Maybe, it might be a small diagnosis. It might be, an accident that might happen because he's just learned to ride a bicycle. It might be anything. So we are protective about our children. So we have to understand that side of the parents. And that generally means that we are empathizing with the parents. Okay. But having said this, we need to also make them understand that, if he doesn't come to know, you will be at a loss because you will never come to know what he would have done after he is cured. Okay, so we must give him that sense that he may not have a long time to live, and we have to make the parents understand that whatever time is left with the child, he needs to live it to the full. Okay, and also the other part of the story is about the child, because he's already asked the doctor about it. That generally means that he has actually come to know of, or he's already got an indication that something is seriously wrong with me. You have to, there will be a lot of emotional outbursts when you talk to the parents about it. There'll be a lot of resistance. You may have to sit with them for 2, 3, 4, 5 sessions also, and make them understand it. But until and unless you get a green signal from the parents that, okay, I think you're right, we need to tell this to our son. Okay, that will actually bring them together, and you have to give them their time to cross these informations, talk to each other in private, and be ready to face a lot of outbursts at that particular point of time. You need to maintain the privacy of the family. You need to give them a sacred, private space where they can do this interaction. And then you can actually handle the situation in a much better position. So that is how you do it. And of course, 90% of the answers regarding this particular question is absolutely right, but it depends on how we lead the conversation, and that will generally determine the outcome. And our intention is that we have to tell the child, not in a manner which will offend the parents. And that is because we understand that the parents are trying to protect the child from getting hurt. Okay, so this is how you manage such situation.
Ma'am,
So,
Doctor, can I take a question, or you want to
yeah,
take it at the end of the session?
sure. Yes.
Dr. Aishwarya is asking, ma'am, I have a question regarding getting the parents on board first. Dr. Aishwarya, you can unmute and ask, Doctor.
Yeah, please.
Yes, ma'am. Ma'am, so there might be times where I know this will be rare, but there might be times where the parents might not have the best interest of the child in mind. I'm not saying like physiologically, of course, and like psychologically, that's the most normal reaction. However, in some cases, maybe there is a malintention. So, ma'am, what if the parents never come around to letting their child know? What do you do in that case?
What is your take? What would you have done?
Ma'am, I would have disclosed. Like if the parents never came around to it, then like I would initially try to understand why they don't want the child to know. And maybe if they're saying that the child might not be able to take it, then I would try to also have a mental evaluation of the patient, like if they're being honest about it, as in if the patient is of course it's a hard news, but then if he or she can understand it and function normally regardless, then I would disclose it if I personally think that the parents might not be doing justice to the child.
But then, that would create a hostile situation. Do you want that situation in your hospital?
No, ma'am, definitely I do understand what you're saying, but then, ma'am, that is what I'm asking, that in this case, if the parents never come on board with disclosing the diagnosis, like what is to be done then?
So basically, you must understand one thing, that we are not gods.
Yes, ma'am.
Yeah.
Yes, ma'am.
We are here to help the patient and the patient's relatives, parents, or whoever is there with the patient. Okay. So
Yes,
when
ma'am.
you think that you are not the problem solver, you get the problem 50% solved. Otherwise, if you think that I am there to solve and I must solve it, I think no problem is going to be solved. So you have to accept the fact that even we can fail after learning palliative care communication skills to the highest order, because practically many things may not be possible. Second
Yes,
thing
ma'am.
that I want to tell you is that, if you think that the child or the parents are not with that intention of helping the child, I would like to say that maybe you are assuming things.
Ma'am, like there are cases of Munchausen by proxy. So, ma'am, like I'm talking about in that respect, not the like if I see signs of it, or ma'am, through the history or something, then do you reveal to the child or not?
No, I will not reveal that to the child until and unless, I have the parents with me.
Okay, ma'am.
Yeah.
Yes,
And,
ma'am.
for the rest of the time that the child is there with us in the hospital, there even if the parents have some malintention, that will not be fulfilled. So I will see to it that the child is admitted all the time in the hospital till the parents are on board with me in the same platform.
Okay,
And
ma'am.
instead of going and telling the child that yes, it is your right to know, I would actually channelize all my energy to counsel the parents, find out the truth, and also, prove myself wrong that I am thinking that the child's parents have malintentions. Do you understand what I'm
Yes,
saying?
ma'am. Yes, ma'am. Thank you, ma'am.
So channelize your energy in this kind of situations to counsel the parents, to find out their fears. There might be a lot of family dynamics going on. Especially this happens definitely with rich. I won't say it doesn't happen. It happens with, where there are stepmothers and stepfathers, and all these family dynamics do come into play. I'm not saying that this situation is not there. It is there, but so you have to take into account all these things, and always remember that if you have the slightest degree of suspicion that the child is not safe, then the safest place for the child is in the hospital. I
Okay,
hope
ma'am. Yes,
you agree
ma'am.
with my, yeah.
Yes, ma'am. Thank you, ma'am.
Yeah, okay. So we go on to the next scenario, where this is a 50-year-old lady. She has a carcinoma of the stomach. She has come to the hospital in the terminal stage, and the terminality is probably due to some internal bleeding of her last stage cancer. Okay, so when you examine her, you see that the systolic BP is just 50. She's extremely restless. Now, my question is, will you give her parenteral midazolam, which might actually hasten death? And just to let you know that midazolam is the drug of choice for terminal restlessness. Now, I want an answer from the house on this particular case. Anyone?
It's S from Dr. Abdullah. All are saying S, ma'am. Dr. Sharad Babu, Dr. Abdullah.
Okay.
Also,
But
Dr.
then,
Sharad, they told
if
no. One has told no and one has told S.
okay. But then, it's going to actually, it might cause death of the patient. Your colleagues will be the first one to actually catch you by the neck and say, What have you done? You've killed him. You've killed the patient. What will you say?
Participants,
So,
would anyone like to unmute and answer this?
yeah,
Ma'am,
yes.
in terms of as the lady is very restless, so the first principle of the ethical principle itself is not satisfied. That is, the patient is in no state of autonomy to make her decision. So I think in this state, taking over her autonomy and giving any drug of choice. So what I would do is this: what are the because there is a treatable cause. I mean, the restless. If we can treat the bleeding and fluid resuscitation is done and her restlessness comes down, then probably we can ask her like the autonomy. We take her autonomy into consideration and then we might able to treat with her restlessness with midazolam with her consent. That is what I think. So autonomy, because she is very restless and not able to make a decision. So the very first principle is not satisfied. So we taking over taking the decision of hastening the death is not yet.
So
I mean,
basically, uh, if you have seen a patient of last stage CA stomach with, you know, internal bleeding, with a systolic blood pressure of just 50 millimeter of mercury in a restless condition, uh, the patient actually is in a semi-conscious state. Okay. You may not have the time to resuscitate her from that particular position, because she might be as well going downhill and might die with restlessness. So, my question was, the drug of choice for terminal restlessness in palliative medicine is intravenous midazolam. Will you actually advocate midazolam for her?
still no. Still no.
Still no. Okay.
If
You are
not
you are-
if not that. If not the
okay.
autonomy, it is not
I
legally
understood.
correct.
I understood your point, sir. I
Yes.
understood your point. Now I want to ask those people who have said yes to midazolam, why will you give midazolam to her? I have understood that's the treatment of choice. I've already told. Now, how will you actually defend? I'm actually trying to turn around the question. How will you defend your stand on giving parenteral midazolam?
Ma'am, actually, it states that the patient is already in terminal stage. So obviously, we will also try to resuscitate the patient, but at the same time, to treat the restlessness without the permission of the patient, without the consent, because obviously the patient won't be in the absolute state of mind. Like he might not, the patient might not be in the perfect state of giving the consent. And I don't think her relatives or also can also give the consent to give midazolam or not.
No,
So I
the
think
relatives don't understand. The relatives would actually tell you, doctor, do something. She's so restless. She's
yes.
having such a bit of suffering. We can't see her like this. Do
Mhm.
something. So what will you do? You know that midazolam is going to treat the restlessness that she is suffering from,
Mhm.
but at the same time you also know that midazolam might actually cause death of the person. So now my question is, how will you give your stand for use of midazolam?
Dr. Sharath is saying, ma'am, hastening death is active euthanasia, which is not legal in India.
Oh my God! Please don't come to euthanasia so soon. Okay, all
Dr.
right.
Neha and Dr. Shaheen have told S for midazolam. I think from these two, anyone can answer.
Yeah, if I can get one small explanation to why they have said yes, that's the only point I want to answer, because that is going to give you the other leads that I'm going to explain now.
When the patient is in the end stages, she is going to die either like say now or in a couple of days. But my most important thing is to keep the patient comfortable in her last days. So I would give it.
So I am the oncologist, or I am from the medicine department, and I tell you in front of everybody, you have actually caused the death of the patient. How can you do this? This is so unethical.
Ma'am,
What will you tell me? How will you defend yourself? All right. So this is like, the question is it right to give some medication to a terminally ill person which may inadvertently hasten the person's death? When we talk, when we say inadvertent, it literally means that we didn't have the intention, right? So what was our intention of giving midazolam? Our sole intention was to calm her down, give her that comfort from the restlessness that she was suffering from. Okay? So always follow the principle of double effect. And it states that a single act having two possible forcing effects, one good and one harmful, is not always morally prohibited if the harmful effect is not intended. Okay? When I say harmful effect is not intended, that means it's our intention is inadvertent. Here, midazolam has two possible forcing effects. Number one is good, which is calming the patient down, relieving her of restlessness. And the second one is harmful. Okay, and the harmful effect is causing the death, or taking the patient towards death. Our intention is actually not causing death. Our intention is to calm her down. And this particular principle is seen in almost all the medications that we use. Say, for example, we are using hypoglycemic drugs for a diabetic patient. He knows that if I don't have my antihypoglycemics today, tomorrow my sugar is going to shoot up. But then having, anti-hypoglycemic agents might also lead him to fall into a severe hypoglycemia. So are we intending to put him into hypoglycemia? No. Our intention is to maintain his sugar level. I'll give you another interesting example. We use morphine tablets to take care of severe cancer pain. But then it has its own set of side effects. Are we intending to put him into those side effects? No. Our intention is to take care of the severe pain that he's suffering from. Okay? So in case of midazolam also, it is the same. So our intention, please don't go into, the confusing states of euthanasia and things. For euthanasia, I'm coming to that actually, but it's not like that. Please do not confuse. It is always the principle of double effect, which applies to therapeutic as well as non-therapeutic, non-therapeutic procedures that we do. All right. So always keep this thing in mind. And when you explain with your calm and your posture maintained to all your colleagues, they will just look at you and they will understand what you are saying. And I'll tell you, this has happened with many of our colleagues, including me, a number of times. So you have to consider the principle of double effect. Okay. I hope I'm able to satisfy everybody's concerns, or is there any confusion in this state?
I think you're clear, ma'am, but let's wait for the others' response also.
Okay, all right. So I'm taking you to another dilemma. See, we are learning about ethics, that's true. We will learn ethics only through the situations that we face. And all these situations, are so rampant in our day-to-day practice, whether it is medicine, whether it is surgery, whether it is palliative care, it's always there. And the best thing that we can do is to break down these situations into, uh, points, or maybe certain bullets that are going to give us an explanation of the whole situation in a very kind of explainable manner, so that we know what to address, which part to address, and how to address them. Okay, so we are talking about a 74-year-old gentleman, and he has an advanced cancer of the lung, who had completed a course of radiotherapy and 2 courses of chemotherapy. He is brought to the casualty now. He is drowsy, his pulse is feeble, systolic BP is 60, and his breathing pattern is altered. The family now wanted everything possible done for him. So what do we do in such a situation? So you have to see that he is a 74-year-old gentleman. He has advanced CS of the lungs and already had his share of treatments. And presently, his clinical scenario is actually showing that he is going downhill. Okay, he is absolutely terminal. But the family is here who would want everything. Okay, they are forcing you to resuscitate him and shift him to the ICU. Will you do that? They are telling that, you need to investigate, you need to do a CT scan once again, you need to do a CT brain or CT lung or whatever once again. Okay, you must also give him everything, including ventilatory support and hydration and nutrition. So what do we do in such a situation? So basically, when we talk about our terminal patients who are going to die or are in a dying stage, we have to see what is the appropriate treatment. And what does it mean? It means that the treatment that does not provide net benefit to the patient may ethically and legally be withdrawn, and the goal of medicine should shift to palliation of symptoms. Okay, so this particular gentleman will need an appropriate treatment for him, maybe a small IV line, a bit of oxygen, and not ventilatory support at all. And of course, no way are we going to shift him to the ICU. And that's where you need to sit with the family, explain to them that even if you want it, we are not in a position to do it, because it is not going to do anything to him. It is in fact going to increase his sufferings. So the key points are, we have to look for patient's biological prospects. When we decide about an appropriate treatment, we need to look at the patient's biological prospects, the therapeutic aim and benefits of each treatment that we have planned, each measure that we will take for such a patient, the adverse effects of each treatment. Okay, whether it is a simple hydration and nutrition measure, we still need to find out, we need to consider the adverse effect of such a measure, and the need of not to prescribe a lingering death for our patients. And that's what the appropriate treatment means in terminal illness in palliative care. So this brings to the last part of our ethical principles, which is the principle of justice. And that means the balancing the needs of the individual with that of the society. There are, you can give many examples. The previous example was also a good example of utilization of resources in a fair and justifiable manner. For this particular case also, an 86-year-old gentleman, also, with all kinds of problems now landing up in a increasing breathlessness, will you actually consider ICU admission? And if you do consider, or if you are pressurized actually to shift such kind of patients to the ICU, are we actually utilizing our resources in a fair manner? And of course, in a country like India, where we have limited resources, those people those doctors here who are working in a government setup will find it very difficult to refuse a patient for some kind of an admission and allot a bed to somebody who needs it. So justice is all about fair utilization of the available resources. So that brings us to the question of euthanasia. I would like to reiterate that by using midazolam, we are not doing euthanasia. And why? I'll explain now. Because euthanasia per se is an act or procedure in which someone takes an active means, okay, such as a lethal injection to bring about someone's death. Having said this, when we allow natural deaths to occur by withholding certain measures or withdrawing a futile treatment, cannot amount to euthanasia. Okay, so, well, somebody said that it's not legal in India. Of course, it can never be legal in India. Okay, and where it is legal: Netherlands, Belgium, and some few parts of the world, they have made it legal. But there also the civil society is actually fighting it out to make it illegal, because euthanasia can never be active or passive. Euthanasia is actively killing somebody, bringing about somebody's death, and that is always an active measure. It cannot be a passive measure. So basically, I'm talking about a legal provision, but this has now been, taken, to a very high standard, where we have had a lot of, deliberations in the Supreme Court of India. And I'm sure Krishna is there. Krishna can actually share you the latest guidelines that rules euthanasia and withholding and withdrawing life-sustaining measures. Not going into that detail, but always I would like to, tell you about the AMA Code of Medical Ethics, which states that which states that physicians are not ethically obligated to deliver care that, in their best professional judgment, will not have a reasonable chance of benefiting their patients. So always look into this AMA Code of Medical Ethics. This has been actually, there are other versions of this also. You can actually look at the Code of Medical Ethics. There have been other, I think 2015 and onwards also, there are other better explanations have been given. So basically, why do doctors go for futile treatments? So obviously, not orient. They are no. They do not have any training in palliative care. always oriented towards curative treatment. Always, I have to cure this patient. I'm born to cure this patient. If I am not able to save my patient, what is my use of being a doctor? So these are things, these are problems that our physicians actually face. Of course, fear of being blamed for suboptimal treatment. Why didn't you give this vitamin to my patient? This would have actually saved him. Why didn't you give that injection? So all these things are actually the fear of being blamed for suboptimal treatment, and then ignorance about the guidelines for end of life care, and of course the ethical problems that revolves in and around euthanasia, especially for those who are working in the ICU and have to actually take decisions on whether to withdraw or withheld certain measures. Or maybe you can actually refer to this particular paper, which is End of Life Care Policy and Integrated Care Plan for the Dying. It's a joint position statement of the Indian Society of Critical Care Medicine and the Indian Association of Palliative Care. So they have very nicely actually given a 12-step approach to end of life care, and a policy has been actually floated, which can actually guide a doctor, a palliative care team, an ICU team to actually follow those steps and take the best possible decision for a patient and within ethical standards and limits. So, if we talk about euthanasia, we have to understand what is the difference between killing and letting die. So, there is definitely a moral distinction, and the question is in what circumstance is it morally justifiable for not to offer life prolonging and life sustaining treatment? So we need to understand this moral distinction between killing and between letting die, and the justification of not offering life prolonging and life sustaining treatments. So basically, always understand that it is a deliberate intervention undertaken with the expressed intention of ending life to relieve intractable suffering. See, your intention may be good, that I want to relieve the patient of his suffering, but you just can't kill the patient for that. Okay, you do not have any right to do that. So basically, euthanasia is an active euthanasia. There can never be a passive thing related to that. So the questions of do not resuscitate, and many other, clauses that have come up would actually take you out of this particular situation and empower you to take a good decision, and also give your patients or the patient party, if the patient is not in that particular mindset or in that capability to take a decision whether to resuscitate or not resuscitate, if such a situation comes up in during his or her illness. So using morphine and any other drugs to relieve pain is not euthanasia. Stopping the treatment when the burdens outweighs the benefits is absolutely not euthanasia. And allowing nature to take its course and henceforth, allowing natural death to come is not at all euthanasia. Okay. So whatever I have talked about is actually people might actually term that as passive euthanasia. Okay, you are passively leading the person to death. No, there is nothing called passive euthanasia. Euthanasia is always active. So if you are interested, please go through this book of by Dr. Atul Gawande. um, he has so explicitly, so beautifully given such beautiful situations from his own case studies and these are actually can be learned, and adopted to your own systems of practice, because this the ethics part is actually something which will always bother you. It's not going to leave you at all. Even if you leave medicine, it's not going to leave you. So we we generally in India, we can't afford to die in the ICU also. That is one fact, because almost 85% of our healthcare spending is India is out of the pocket. And the Lancet in 2011 study, they've actually brought out this statistics that 39 million Indians are becoming poorer per year due to rising healthcare costs. And you know what it is like. Most of this cost is related to aggressive medical interventions at the end of life. We have to, if you see, every hospital generally makes money out of the ICU care. So you know what it is like. There will be a 300% increase in inpatient expenditure in the last 10 years. So, these are the statistics. And the take home message for us is apply the ethical principles against a background of respect for life, the acceptance of the ultimate inevitability of death, and at the same time, always, back up all your knowledge with a lot of, evidence-based medicine. So, I would generally want to die like this lady who's surrounded by all her relatives at home, and not, surrounded by machines and the, in a strange condition where I do not have my familiar room. So thank you so much for a patient hearing, and I end my presentation here. If we have any questions, I'm ready to answer them. So thank you so much.
Thank you, ma'am. Thank you. Thanks for the excellent presentation, ma'am. And we don't have any class, no case presentation today, so we can directly go to the questions. There's one question in the chat box from Dr. Mayuri. How is assisted dying different from euthanasia? Are these terms interchangeable?
No, not at all. They are not interchangeable. And in fact, we also do not do assisted dying. Assisted dying, euthanasia, they are not interchangeable as such, but they are in a way, if I have to say in a very blunt manner, they are actually killing the patient. You are assisting the patient to die. You are bringing a rope for your friend to tie, in the ceiling and die. So that is assisted dying. Okay. And euthanasia is anyway like you are actually doing it actively. You are tying the rope in your friend's neck. So I would actually say in that manner. I mean, that's how I can explain it. It cannot be interchangeable.
Ma'am, Dr. Madhusudan is asking, is in DNR, can we do CPR?
That is, see, do not resuscitate itself means that you are not allowed to do CPR. Okay. Unless and until, you are doing CPR on a person who has fainted in the mall in front of you, and you are actually trying to save his life. Any other question? Sorry, I can't hear you.
What about the patient is asking you to hasten?
I'm sincerely not able to hear you actually.
Ma'am, she's asking if the patient is asking you to hasten his death, his or her death. That's what you're asking, Dr. Mayuri?
Yes.
So will you do that to your relative?
Dr. Mayuri, unmute yourself. We can't hear you.
Sorry, I can't hear her actually. No, you can type out if it is a problem.
Okay. We have one question from Dr. Shaukat ma'am. Giving midazolam to a patient who is in shock, hypoxic and restless, does that amount to negligence?
Yes, it doesn't. Definitely it doesn't. Because you are actually prioritizing the whole symptoms. Okay, so number one definitely would be restlessness, because the patient is tossing from this side to that side, is uncontrollable, and you have to calm down a patient. If not with physical means, then definitely with medication. So that is the reason why you are giving midazolam, and that justifies it.
Madam, good evening, madam.
Yeah, good evening, sir.
Madam, in ICU patients, most of the patient last stage, intubated patient attend want to go home. In that situation, shall we remove the ET tube and all, or else send them along with the ET tube?
So,
If we remove the ET tube, there itself the patient will die.
yeah. So basically, when I was talking about withholding and withdrawing treatment or any measure, I meant that if that particular measure is outweighing the benefits of the patient, then you definitely can actually withdraw or withhold that particular treatment, whether it is an intubated patient, whether it is a patient who needs, a different, interventional support. You can always do that. And that is the reason why now the withholding and withdrawing treatment has actually been, in the legal perspective, totally belonging to the class of DNR, because you need to take a do not resuscitate or the written consent of the patient or the patient party when a terminal illness is concerned. But if the patient is not terminal and the patient party wants to take the patient home, then definitely it becomes illegal, or definitely it becomes unethical. So you have to weigh the benefits along with the burdens of treatment. So that will actually justify it.
Ma'am, Dr. Mayuri had typed the message. She was not clear at the time. I'm
Okay.
asking you to show us the correct way of dealing with a situation where the patient is requesting us to hasten the end.
Okay. So there is a situation here, the patient is asking, you have to find out why. Okay. Is the patient suffering too much with pain or symptoms? Is the patient not actually getting relief of the psychological problems that he is facing? Is the patient, have you actually talked to the patient why he is asking you to end his life? So you have to, again, the same process of actually talking to the patient, talking to the patient party, letting them know that the patient is actually telling this thing. Why is it like that? What is the bother? What is the fact that is bothering this patient? Okay, there'd be so many things. He might be actually thinking that, oh, I am dying, so what is the use of living this life, or life in this particular bed? Why am I becoming a, the sense of guilt? I'm becoming a burden on my family, because they are losing on the finances, and I know that I'm not getting better. So so the guilt, feeling of guilt, you have to bring in, if you do not have the time, or maybe if you're not an expert in that particular area, might as well think about bringing in a counselor who has the experience of talking to patients who are in the deathbed. And uh, under no circumstance will you actually leave the patient alone if the patient is actually showing you signs of trying to die. Because if there is nobody in the ward, nobody in the room, the patient might as well want to commit a suicide. So you know that patient is actually suffering from some kind of depression, or maybe slipping into clinical depression, and you need to treat that medically. Is that okay, Dr. Mayuri?
Yeah, she showed her thumb, ma'am.
Okay.
Ma'am,
Thank you.
Dr. Neha is asking, if a patient on ventilator is brain dead, relatives want to discontinue treatment, can we give vecuronium and disconnect? Will this be euthanasia?
Can you please repeat the question?
If a patient on ventilator is brain dead and the
Yeah.
relatives want to discontinue treatment, can we give vecuronium, ma'am? It's VECURONIUM,
Yeah.
and disconnect? Will this be euthanasia?
See, this is a very dicey situation because you're mentioning about the brain death of the patient. Okay. And when the patient is brain dead, we need to visit the legal perspectives as to what does brain death in India means. Okay. That is a different chapter altogether, but I think Krishna will be able to share the advanced care directives and the legal aspects surrounding it, because we already have a good legal standing on patients on brain death, and usage of certain drugs, and then withholding and withdrawing treatment. Okay, so this particular situation falls under this law. And it's not only you that will decide usage of vecuronium and withdrawing the ventilator because the patient is brain dead. You will or you may have to actually consider forming a primary and a second primary board to decide on this particular patient. And also the primary board, if not satisfied with their decision, might have to go to a secondary board, which may be constituted by a first class magistrate and a few people from the judiciary and the director of your institute. So I know I'm confusing you, but you need to actually go through the advanced care directives. And Krishna, can you please share that with everybody? I think they'll get a good
Sure, ma'am, sure.
yeah. Because for medical ethics, I really didn't have the time to actually include anything from advanced care directives.
We will be having a class on that, ma'am.
Oh, that's
On
great.
living will
Yeah.
be.
Yeah. That will be nice. Yeah.
Ma'am, Dr. Aishwarya is asking, ma'am, are there ways to actually prove your intent? What if it's just one person's word who says I was negligent against my word, where I'm just stating the rule you had explained?
So basically, you alone will have to always prove yourself. There'll be nobody else. Of course, if it goes to a court, then definitely there'll be your lawyer, but then the lawyer will also depend on what you say. So basically, you are alone. So when you're alone, my stand, if I am in your place, I would actually practice something which is called evidence-based medicine, number one. Number two, the rule is actually, a rule that is underlined for all the medications and all the treatment procedures that we do. So henceforth, the rule is a thumb rule, and the thing that are going to protect us is the evidence-based medicine practice. Okay, if you do not do that and you try to give that rule, it's not really going to help you. So you have to take help of the latest guidelines of using a proper medication. For example, I'll give you a small example, So basically, until, very recently, for any kind of wound, surgical wound or any wound, we were taught to use iodine-based solutions to clean it up. Of course, nowadays also they clean, but the evidence as of now says that iodine generally kills the cells that are regrowing in the area of the surgical wound. So it is against that. We must not use iodine-based solutions to even clean the wound, clean any sort of wound. The only thing that is applicable is clear saline water, okay, or distilled water. That is the evidence now. Okay. Now, if in that, if that is the case, and somebody actually tells you ki, oh, you are not using betadine ointment or betadine solution to clean my wound, you can always tell them, you can always give them this evidence. So this is a small example I'm giving. So basically, you have to have a proper background of evidence-based medicine. And if you don't, then you are in trouble, actually. Yeah.
Ma'am, Dr. Shaukat has a lot of questions. I mean, Dr. Shaukat, can you unmute and ask, because I'll not be able to answer or I'll ask all your questions. Dr. Shaukat, you're there with us? Okay, ma'am.
Can a patient donate organs after euthanasia without having his prior intention?
Previously, also he was asking if a patient is
I
in
didn't understand this question, actually.
That's why I'm asking him to unmute and ask, ma'am. Because when Ma'am, till then, there's one question from Dr. Madhusudan that letting die, is it acceptable in justice, ma'am?
Okay. When I showed you that slide, it is like I wanted to differentiate and make you understand between the differentiation between what is killing, deliberately killing somebody, and letting die someone. Okay. So I'll give you an example. So I've seen my grandfather dying in his home. I was beside him. I was a final MBBS student at that point of time, and he was suffering from a terminal illness, and he died at home. Okay. We didn't take him to the hospital because he was 89 years old. He was not able to come out of his bed. Neither did we want him to suffer after, struggling to get him out of the bed and putting him on the stretcher, then putting him on the, ambulance and drive him to the hospital over a bumpy road, giving him all sort of trouble, and then putting him deliberately inside the hospital, inside the ICU where he would be ventilated. So we let him die in that situation. That is what is letting die. Okay. And that means that we are allowing the nature to take its own course. Okay. The river is flowing from the mountains to the ocean in a certain flow, and that is actually the river is actually taking its own course, a natural course. And that is what we are doing by letting the person die, taking the nature to take its own course. But when we kill someone, it's like, if I have to kill someone, then I'll deliberately, use a kind of a medication to kill that person. I'll inject it. And I know that I'm killing that person. I'm not letting him die. I'm killing that person. Okay. So it amounts to murder, basically, if I have to say so. So
Very,
that
very
is
well
what I
explained.
meant by letting die and murdering or killing a person. So
Well
when
explained.
you say that it is acceptable in justice, I really can't answer that. I mean, so I just wanted to let you know the difference between the two. That's it.
Thank you, ma'am. It was well explained, ma'am. Oh, very well explained, ma'am. And thank you once again. I think Dr. Shaukat, you have unmuted yourself. Do you want to continue?
Yes.
Ma'am, ma'am, we are already past
Yeah,
6:30, but it's
yes,
a couple of minutes. Is that okay?
Fine, no problem.
Yeah, Dr. Shaukat.
Yeah, good evening, ma'am. Basically, regarding the patient where giving a midazolam is not a negligence. First, I want to say that patient is anemic, hypoxic, BP is low. He or she is restless. Then you have to rule out the basic cause first. Can this be a hypoxic injury or it is hypotension? Why we would straightforward give midazolam is not a negligence on our part.
No, sir, I don't think it is a negligence on our part. How can it be negligence?
Basically,
You are
midazolam itself causes hypotension. It causes fall in GCS. Patient
yes,
will
that's right.
desaturate. Yeah.
That's right.
Patient will desaturate, and you
Sir,
are complicating the
what
problem at the
is
same
your,
time.
you tell me what is your intention of giving midazolam?
I don't think midazolam should be given.
You cannot
So
say
you have
that
to
Dr.
you have to
Shaukat,
correct the basic.
Dr. Shaukat, you cannot say that. You cannot say that because the evidence is saying that. The book, I'm going by the book. I'm not actually listening to anybody else. My book in palliative medicine, Oxford textbook says that you have to use midazolam to
But we
treat
are not correcting the
pulmonary
basic cause.
hospital.
Patient is
Dr.
having
Shaukat,
stomach.
Dr. Shaukat, patient is in the terminal phase. He's in the terminal phase.
Are we able to defend this thing in the court of law?
Yes,
This is not a
absolutely we are. Absolutely we are. That is why we are talking about medical ethics today. We are able to defend ourselves in the court of law.
As far as the medical literature goes regarding the midazolam, these are the things that midazolam can lead to.
There are many things that midazolam can lead to. You can actually
patient is already.
I think, sir, you should revisit the Oxford textbook of palliative medicine and get your answers to this.
Okay, thank you.
Yeah.
Dr. Shaukat, you can just read on medical. This is in Oxford textbook of palliative medicine. They have very well explained about terminal restlessness and midazolam. It's really good to read. I have read that personally. You can just go through it, and then still, if you have any doubts, you can always get back to us. You can ask in the group, and we will forward your questions to Dr. To Madam. Right? Is that okay, Dr. Shaukat? Okay. Thank you, ma'am. I think, ma'am, it's already 6:35.
Yeah.
Thank you, ma'am. Thank you. You were so patient with all this thing, and it's a very complicated topic. And
yeah, I know people have a lot of questions and a lot of ifs and buts, but then we have to deal with that also.
Yeah, but you dealt it very nicely, ma'am. Very nice. And really thank you for that. If any more doubts, they'll put in the WhatsApp group, and then Dr. Sangeet may forward to you, ma'am.
Yes,
okay.
yes.
Thank you, ma'am. Thanks a lot. Over to you, Sangeet.
Thank you so much. Thank you.
Thank you, ma'am. Thank you, Dr. Sanghamitra, for the wonderful presentation and patiently answering to all the questions that our participants has asked. Thank you so much for that. Thank you, Sheila, ma'am, for facilitating. Thank you all for participating. Thank you. Let's see you in the next session.